So now we're going to move forward with our first topic of discussion, which is treat to target. So obviously, over the last, I would say, 10 years or so, treat to target strategies have become central to rheumatoid arthritis management. I'd like to first ask John if you could describe the overall approach and its major principles for our audience.
So the Treat to Target Consensus Conference, which was held in the early 2000s in Amsterdam, came up with a set of overarching guidelines.
Now, central to Treat to Target is the notion, as Jonathan correctly pointed out, of assessing disease activity. But as important, as Jonathan also inferred, was using that metric to define therapy. It means nothing to merely do a disease activity measure if you're not going to use it to, in some way, alter or confirm the treatment that you're using.
I'll initiate methotrexate therapy at 15 milligrams weekly, or perhaps even higher. But once I've optimized methotrexate therapy based upon the accumulated information about combination therapy versus monotherapy, I will add targeted biologic therapy to methotrexate.
No, Jonathan is right, though. We have moved away from Gestalt to metrics. But at the same time, we shouldn't move entirely away from the notion of asking the patient how they are and incorporating that to our fundamental metric that we use to determine therapy.
So, Allan, could you give our audience some examples of a case where you might reach for a non-TNF first line?
Sure. There are a couple of reasons why I might reach for non-TNF first line, both predicated on the patient's background medically as well as the patient's preference. So let's deal with the background first. The 2015 ACR guideline, for example, suggested a non-TNF inhibitor might be preferential for a patient with a long history of infections. And in that instance, I might use abatacept, which is thought to have a lower incidence of infections from the literature that we've reviewed so far. And that might be one example.
So what is a biosimilar?
Well, biosimilar is a biopharmaceutical that has been engineered to replicate the reference product or the biooriginator. So a biosimilar is not a generic in that a small molecule can be copied exactly using chemical synthesis. A biopharmaceutical cannot be copied exactly because it's made in living cells.
Some people would prefer to exhaust all oral options before going to an injectable or an infusible. So that is often a problem. I don't have a problem with the treat to target approach, but many of my colleagues see it as a legitimate challenge because, as we've discussed, they have time constraints on the number of patients they can see, and for them, even the additional time of doing a total joint count or calculating a DAS28 becomes, if not an impediment, certainly an inconvenience.
So I would look closely at their index and middle finger to see if there's nicotine staining, or at their teeth to see if there's gingivitis. This is a patient who is at significant risk for developing rheumatoid arthritis, but we don't yet have definite evidence of the disease occurring. It wouldn't hurt to put this patient on a medication such as hydroxychloroquine, which might take effect in a couple of months, might be beneficial, low toxicity. But I would see this patient back relatively shortly afterwards, see them early in the morning so that I could detect joint swelling if present, and I might have a colleague who performs musculoskeletal ultrasound look with powered Doppler to see if there's evidence of increased blood flow in the synovium.